page. So we appreciate that, David. But David joined the Huntsville Hospital in 2006 as the CEO. Today, the organization is known as Huntsville Hospital Health System, third largest publicly owned hospital system in the nation. Serves North Alabama and Southern Tennessee. During David's tenure as CEO, Huntsville Hospital has grown from one hospital to 11 owned facilities, one managed facility, and affiliation relationships with 2 other hospitals. Numerous non-acute care entities and physicians are now also members of the system, and the number of employees has grown from 4,000 to over 15,000 team members. So quite a bit of growth in that time, that's for sure. Recently, Huntsville Hospital was recognized nationally as the second best hospital in Alabama by the U.S. News and World Report. No one pays attention to UAB down south anyway. Prior to joining Huntsville Hospital, David was at Mission Health, a large integrated healthcare system in Asheville, North Carolina, for 18 years. Originally joining as the CIO, and over those 18 years, a variety of positions were held, including CFO and COO before coming to Huntsville. David originally started his career in software development for the healthcare industry, received an undergraduate degree in information technology and business administration, and a master's degree from the University of Miami. Currently, David is serving on a variety of community and professional boards, including service as the immediate past chair of Vizient Southeast, an association of 33 health systems in Alabama and Florida, a board member of Wolford College in Naples, Florida, and he also served as chair of the Alabama Hospital Association. David's wife is Cindy. They both grew up in York, South Carolina, been married since 1983. 2 small tidbits personally of David that I'm aware of is one, he definitely likes to golf once in a while, avid golfer, so watch out if he challenges you to a match. And secondly, David also has passion. Obviously, he's got a passion for people and care and for folks in general, but he's big on rescuing animals and has a passion for animals as well. So this kind of speaks to the kind of person he is. So David, welcome to the meeting, and we're definitely honored to have you today.
Thank you. Appreciate being here. That's the long version of my bio. I actually prefer a shorter one, but when you've been doing this for a long time, you can actually get a pretty long bio whether you want it or not. So you have that. I'm going to see if I can't do my screen share here and get things. Okay. All right. Is it working? Can everybody see my?
Looks good here.
Yes,
Okay,
it's
good.
working good.
Yeah, looks good.
Okay. Well, appreciate the opportunity to spend some time on Zoom with you. Look forward to a time when we can do this again in person. Well, that's one thing I've surely missed is COVID is the face-to-face meetings and chamber meetings and things like that. Zoom is wonderful. Didn't know it existed before COVID, but it's just not the same as seeing people face-to-face. So I'll run through this a little bit harder to ask questions in the middle of a presentation with Zoom, but if you save your questions at the end, I will stay as long as you want to talk when I finish the presentation. So 2020 was supposed to be a very big year for us, 125-year anniversary. We had a lot of things planned for the 125th anniversary. Needless to say, COVID put an end to that, but still very proud to be working for an organization that's served this community for 125 years and a not-for-profit public organization that's done this for 125 years. Quite a history, obviously grown quite a bit. That's part of being here in Huntsville that's had such a wonderful community to live in. I've been here now, going on 15 years. As was mentioned earlier, I came from Asheville, North Carolina. There are many people who will tell you Asheville is kind of one of the premier locations where people want to live in the United States. And I've been here, I was there 18 years. I've been here 15 years. I far prefer this to Asheville, North Carolina. If you ever have any wish to go to Asheville, it is a beautiful community, but the people here are so much more genuine. I love the diversity of this community. Just love everything about this community. So be proud of the organization you live in. I surely am. I mentioned, 125 years. We are a public not-for-profit. We're actually incorporated in the state of Alabama as a healthcare authority. Our board is appointed by the city of Huntsville. We have an interesting relationship with that. We're an independent entity, but in order to be an authority hospital, a public entity, public organization like the city or county has to appoint your board members. We operate a little bit like a 501c3. When there's a vacancy, we interview candidates for the board and we give the city council 3 names and they select any of those 3. So there is some independence. Our board doesn't get to dictate who's on the board, except that they do give the 3 names to the city and the city has to choose one of those 3. A little unusual, but I think that's one of the reasons we've been successful is our board, which are the people there, the 9 board members there in that middle picture. They all volunteer. They spend an enormous amount of time helping us grow the organization and work on the things that we're working on. Phil Bentley, second from the left, is the board chair. He's only the second board chair I had. When I got here, I had a gentleman by the name of Russ Brown who got ill and passed away, and then Phil took over. Phil is in his 20th year on the board. Seems like a long time. Some people wonder about, is that too long? I will tell you, it's just a complex business. When you get board members that understand it, it's nice to have continuity and understanding. And all of our board members are at least in their 2nd term, in their 6-year term. So we have a lot of wisdom on our board, and we rely heavily on them. There are about a third of the hospitals in Alabama are public. We are an anomaly in that we're one of the few that don't get any tax support. Public hospitals in general exist for a different purpose than for-profit hospitals. For-profit hospitals they exist to make money. That's what they're in the business for. It's not a bad thing. Apple sells iPhones to make money. For-profit hospitals sell healthcare to make money. Not necessarily a bad thing. It's just a different reason to exist. We exist to try to provide healthcare that makes this a better place to live. And many of the services we provide don't make money. Ooh, well, we'll get rid of that. I can tell you that virtually all of our pediatric services lose money. Our trauma center loses money. And I could go through a list of other services that lose money. And that's why most of the public hospitals receive tax support, because they have to subsidize these programs. But we provide these services because if we did not have these services, then I don't think Huntsville would be the kind of place a lot of people chose to relocate. And a lot of large employers like Toyota, Mazda, and others would not have moved here if we didn't have a robust healthcare system. So we're a safety net provider. We do not receive any tax support. We've been able to do without that. We'll tell you at times it gets harder. I will also tell you that 10 years from now, there will be far more public hospitals that exist. Most are struggling to survive because they end up having to take not all, but a majority of the indigent care and the Medicaid and the services that don't make money. If you go up to Chattanooga right now, Erlanger is struggling. People are trying to buy Erlanger. They're making hostile bids to try to take over Erlanger, convert it from a government hospital to a for-profit hospital, because they just struggle with their mission in a community where they've got a lot of competition for the paying patients. The last thing I'll say about Huntsville is on this slide is, I've heard every once in a while somebody say, well, Huntsville's a monopoly. And yeah, and to some degree we are. We're a big system. I'll talk about that in a minute. But I will promise you, we've got a monopoly on the services that don't pay well and the things that aren't reimbursed well. For anything that makes money, there are plenty of options out there for people who want to go to those organizations. When you look at ambulatory services, whether it be surgery or imaging or any other thing that's provided in an ambulatory setting, which is where a lot of the profits in healthcare are these days, there are numerous providers of those services. But we do not have competition for pediatric emergency department, pediatric general surgery, pediatric neurology, trauma center, I go down the list, because those things are not where people want to be if they're in the business to make money. Wow, 2020, go back to it again. It's been quite a year. What I'd like to say with this slide is to all of you and all of the Huntsville and surrounding communities, we appreciate the support. It's been very touching the way people have contacted our organizations to help, what they've done for our nursing and clinical staff that's working every day trying to take care of these COVID patients, which are very difficult to take care of. We've had companies provide masks, we've had companies provide meals, we've had companies provide car washes for employees, you name it. A lot of things have happened that have made this manageable for our community, for our organization, been greatly appreciated. The bottom of that screen, the fever and flu clinic, has been a phenomenal success. We had a couple of our leaders came to us and said early on they thought we needed to do this. And we've averaged close to 200 patients a day at that flu and fever clinic since COVID started. That's where people go get their rapid testing, and created an opportunity for people to get tested that needed tested and keep them out of the emergency department. It's been a tremendous success. Although it's been so successful, I wish it'd go away because I wish we didn't need it anymore, but probably going to be here for a while. I thought I'd share this slide with you. A lot of people are curious about kind of the statistics behind COVID in Alabama. Here's some information to share. I can make these available if you want them. I think we did share the presentation, so I don't mind anybody having the presentation if you want the data, but shows you how many people have tested, and you know how many people have tested for diagnostic testing. Is close to 1 million now, and the antibody tests about 55,000, but also goes into a little bit of the characteristics of the people who have gotten COVID. It has not been, the people who've gotten COVID has not shared the same demographics as the state of Alabama, particularly when you look at the people who have struggled with COVID. But just race alone, you see some disparities in the percentage of people who have gotten COVID relative to the demographics of the state. More females than males have gotten COVID, but more males than females have died of COVID. If you look at this next slide, which is looking at the cases and the deaths, which we don't talk much about, nobody wants to talk about it, but there have been, almost 2,000 people have died of COVID in the state of Alabama, so there's been quite a few people who passed away. And as you've all heard, virtually nobody dies of COVID unless they have some other complicating healthcare, some complicated comorbidity. And you can see at the bottom left, the comorbidities that people had. 65% of the people who died had cardiovascular disease. But if you look in Alabama, most everybody over 60 candidly has some form of cardiovascular disease, whether it be high blood pressure or some other type of cardiac related issue. We have a lot of lung issues in the state of Alabama. We have a lot of diabetes in the state of Alabama. So one of the reasons we've had a large number of deaths is we have a very unhealthy population, and that unhealthy population really struggles with COVID. You can also look at race, a lot of disparities in race and who's died with COVID. But again, there are some issues relative to race, and blacks in Alabama have higher percentage of people with heart disease and diabetes and whites and that type of thing. So it kind of goes back to really the comorbidities. But again, if you look at the 2,000 people that have passed away, there have been 75 deaths, I think, that they're saying that had no other pre-existing condition. Most of those people, the median age was 72, youngest was 33, the oldest was 103. I was surprised to see somebody with 103 had 0 other pre-existing conditions. I wonder if that's actually correct. But I thought this data was rather interesting, and I'm surprised it hasn't been published more in the state, because I get asked these questions all the time. Here's a snapshot of our health system. We were on a call this morning at 10:30 going through our statistics. We flattened system-wide at about 120 patients. We had 119 this morning. This is yesterday's number. We still have 60 here in Madison County. Yesterday, we discharged 8 patients and we admitted 8 new patients. So we're still getting patients coming in. As we discharge patients, I will say that one of the big changes from early on is that fewer people that are admitted to the hospital now are in the ICU and fewer people are on ventilators. Early on in the COVID, particularly if you remember New York, they put just about everybody on a ventilator. When we've learned a lot about this disease, that's not the best thing. You only have to put certain people on ventilators. So, and you really don't want to put anybody on a vent that you don't need to put on a vent. We've talked, since this has started, we've treated patients with a lot of different drugs early on. We really didn't have any drug designated for COVID. So they tried different drugs here and in other parts of the world. We settled in on a variety of different drugs that people said, oh, this seems to be working. The latest 2 are remdesivir and convalescent plasma. I'll tell you, in the last 2 weeks, there's a lot of data come out that neither one of those drugs seem to make much difference. Steroids now are kind of the drug of choice that people seem to be using a lot. Proning patients, turning them over, having them on their stomach seems to be the one thing that everybody agrees helps patients recover from this, allows them to breathe easier. But right now, in this, here and everywhere else in the country, people are still guessing as to what is the best way to treat a COVID patient. And I was on a phone call last night. We have a weekly call with a bunch of physicians, and we were on that last night, and the infectious disease doctors were debating among themselves what is the best treatment and what are the latest protocols coming out. And it's a little disappointing. We're 6 months into COVID and we don't have good treatments, but then again, we're dealing with a disease that nobody's ever really had to deal with before. So more to come on that. It would be nice if we had better treatments. I do think we're getting a lot more data on the COVID. The COVID that people are catching today is genetically different than the COVID that originated in Wuhan, China. Could be from the same strain, but clearly not as acute as the earlier COVID disease was. Seems to be less deadly. Again, to be determined why. I think there's a lot of unknowns out there right now, but probably the same thing we see in our numbers going down is that fewer people are acutely ill with it as a percentage of the people who get it right now. So we'll move on from COVID, but at the end, I'll be glad to go back and try to address any questions you may have. Pre-COVID, we were going to focus this year on how to grow our health system to take care of our growing community. You probably had presentations from Toyota and all these other companies that are moving to town, and we're looking out the next 5 to 10 years trying to figure out how to make sure we can take care of all the patients that are going to be here in Huntsville. And we embarked on building a brand new bed tower right outside my window, and that bottom right-hand corner is what it's going to look like. And it's moving along. This time next year, we should be in it. We're moving as fast as we can. On the left side that's when they were putting in the new bridge right to the main hospital. But this is going to have additional 72 private rooms. It'll also have 14 overnight rooms and 24 operating rooms, and it'll be connected to the main hospital. We're going to move all of our orthopedic and spine into this hospital or this building, and what that's going to do is free up. We'll go back and renovate those old areas, and will allow us to take care of more patients in the main hospital for general medicine, surgery, and other types of procedures. So it's a big deal for the community. It's a big deal for us. We don't do buildings this big very often. It's a $200 million project. Candidly, I wish we had it today because we needed the capacity when we spiked with our COVID patients, and many of us expect another spike probably in a month or two. We could have used the additional 72 beds. looking at it from the top down with a little drone shot. That's it in the bottom left-hand corner when it was starting. It's 7 floors. It will be the tallest building on campus, even though it's only 7 floors, just because new code requires floor-to-ceiling heights higher than the old floors. And again, moving right along. It'll be a very nice building. One of the interesting characteristics of this building is on the bottom floor, particularly the left-hand side towards the Twickenham building, we're going to have some restaurants and retail space. About half the patients that are treated at the main campus come from outside Madison County. Many of those people need to get out of the hospital, walk around, and get something to eat. So that space was not very conducive for clinical space. So we rented it out. We've got it leased out to a few restaurants to put down there so people have a place to go when they're here visiting a loved one. Our plan is as soon as we get the new bed tower in Huntsville completed, probably within a year, we'll submit a request to the state to add another bed tower to the Madison facility to double the size of Madison. It currently has 90 beds. It's built to go up to 200 beds. We will probably build a building big enough to take it to the full 200 beds and put probably 60 of those in operation if the state will allow us. Going to need that to address the growing community. That's another expensive project, but we need to do it. Some of you know this gentleman, Clinton Carter, is joining us. The previous lady who was our chief financial officer, she went to go run our clinical operations in Morgan County, Kelly Powers, and that freed up the chief financial officer position. We don't have a lot of turnover at the executive level here, so it's kind of unusual to do this, but we had a vacancy. And the interesting thing about Clinton is he is from Madison County. He went to Hazel Green. His family still lives here. He is currently the chief financial officer for the University of North Carolina. He has previously served as the chief financial officer at the state of Alabama on 2 occasions under 2 different administrations. Has his undergrad degree from UNA and his MBA from Wharton School of Business with concentrations in finance, real estate, and public policy. So he knows our community, knows our state well. We think he's a wonderful addition to our team and should be here. Really, I guess, his first official start day is in October, but we already have him working, as you might imagine. It was mentioned in the intro, number 2 in Alabama, UAB's number 1. I'd love to be number 1. A lot of this is based on perception, and we've got a long way to go to catch UAB from a perception standpoint. They are a good organization. They provide great health care. Many of our physicians are trained there. We have a great working relationship with them. We think for the things we do them equally as well, but there are a lot of things they do that we don't do. And we try to make sure that if a patient can't be treated here in Huntsville, that they get to UAB and that we coordinate that care. So blessed to have a UAB in the state, and I think blessed to have Huntsville here in North Alabama. And then the last slide before questions. One of the things that we have wanted to do for a long period of time is expand our health system and get into the basically insurance side of the business. We have started a partnership with the University of Alabama, UAB, and Viva, which is a subsidiary of the University of Alabama in Tuscaloosa, but it's managed by UAB Health System. It is a insurance product. They provide a Medicare Advantage product. And starting January, under joint branding, we will be coming to the market with a Medicare Advantage plan to offer to people who choose to go Medicare Advantage. If you look at the future of Medicare, they want to push everybody from traditional Medicare to Medicare Advantage. And we feel like we need to be in that space. So we'll start that January 1. Yesterday, we were going over our plan design and the coverage and the expectations of what people can expect. And I think it's going to be a very popular product. Medicare Advantage plans are rated on 1 to 5 stars. There are no 5-star. There's only, I think, 10 or 12 5-star plans in the entire country. Viva is a 4.5-star plan. I think there's only one other 4.5-star plan in Alabama. I think most are around 4 stars. So it is very well, they do a very good job with their customers, and you achieve that star rating by taking good care of your customers and providing high quality care. And CMS looks at your care to determine the quality of your care, and they survey your customers to find out if you're taking care of your customers. And the combination of those two is how you get your star rating. Viva does very well on that. So we're excited to bring that to the market. Hope to start here in Madison, Limestone, and Morgan County, and then we'll expand it out to North Alabama over the next few years. So we're pretty excited about that. You know, one slide I thought I had on here, but I guess I didn't. My marketing guy was messing with my slides right before I came on here. I guess he took them out. We are a health system now. We do have the 11 hospitals across North Alabama. And I will tell you, that has served us well during COVID. If I rattled off the hospitals, it's Huntsville, Madison, Athens, Helen Keller, which is in Sheffield, Red Bay, which is in Red Bay, Lawrence is in Moulton, in Decatur, we have Parkway, and we have Decatur Hospital, and we also have the psychiatric hospital, which is out on the Parkway. And then in Morgan County, we have the one in Boaz and the one in Arab. We have a relationship now with the one in Scottsboro. We have a relationship with the one in Russellville, and we have a relationship with the one in Fayetteville, Tennessee. And where that's really benefited us with COVID is all of those hospitals, when we started this, the expectation was that they would take care of their community's COVID patients unless they were critically ill, and then they would ship them to us, because that's what we are here for, is to back up all those hospitals with critical care that they can't provide. We have had very few patients transferred from out in the region to Huntsville, Maine, and that has allowed us to continue to provide non-COVID related health care. If we had not had this system, my guess is at least half the patients in the region, those hospitals would transfer them out so they wouldn't have to deal with them. And Huntsville, Maine would have basically been a COVID hospital. And that would not have worked for the citizens in Madison County. So I've been proud of our hospitals in the region. They have taken very good care of their communities. We have used telemedicine to have the experts here supplement the physicians in those communities when they didn't have infectious disease doctors or critical care pulmonologists, those types of things. And it's worked very well for those communities. It's worked very well for us. The one thing that we are looking at, I mentioned, we really think COVID's a long way from being gone. A little concerned. Some of the models show us really not peaking again until November or December. And then we're going to run into the flu and the COVID combination, which can be very hard to manage. We are looking at taking our Parkway facility in Decatur, we've moved all the acute care patients out of Parkway into the Decatur General Facility. We still run emergency department at Parkway. Can have inpatient capacity, but run a very limited inpatient capacity. We're looking right now at how to convert that to a COVID-specific hospital and put as many of the COVID patients as we can in that hospital, totally different staff, people taking care of those COVID, because we're afraid if we don't do something like that, all of our hospitals are going to be so full when we have this next peak that the ER wait times and wait times to get elective surgeries and those types of things will be unbearable. So we're in the process of looking at that right now. First time I've mentioned it publicly is on this phone call. Hopefully we'll be able to go public with something soon. We think that'll help every one of the communities we serve by having a COVID-specific hospital. And again, we're doing that because we expect COVID to be here for a while. We'd rather prepare for a worst-case scenario, prepare for it being here for a while, and I'd be tickled to death if we wasted our money setting it up and we didn't have to deal with COVID come November and December. So with that, please continue to to practice separation, sanitize, and mask, and hopefully we'll all get through this soon. And I'll be glad to take any questions you might have.
All right, David, thank you so much for your presentation. It's great to hear about all of the expansion and growth that's happening now, as a matter of fact, but also that's planned for the future. I did have a couple questions in line with a comment you made just a moment ago about, you see that as we understand that COVID is probably going to be around for some time to come. Have you seen any spike, small, albeit small, concerning students going back to school yet in this area?
We have not. If there's, in our area, we've seen very little. I've talked to my colleagues that are in Auburn and Tuscaloosa, they have, but to this point, they haven't translated into hospitalizations.
Okay.
And I think the real thing we got to manage with COVID is not whether people get COVID. If everybody got COVID and stayed home and got over it, it wouldn't be a problem. The problem is the impact of the healthcare system when they get overwhelmed with people who require hospital care. If more young people get it and get over it, as long as they don't come into the hospital, that's really not much of a problem.
Okay.
But we need to protect the people who are in nursing homes and assisted living and have comorbidities, because those are the people that are vulnerable if they get COVID.
Okay. Okay. Let me open it up also to the rest of our members. So what questions do you have? Everybody's shy. I do have another question. You mentioned that you see another peak coming in say November, December. Can you tell us why you see that coming? I know it's combined with the flu, but can you expand on that a little bit more?
Yeah, I think, we look at several models. There's one developed by University of Washington. There's another company called the Healthcare Metrics, something or another. And we look at a couple of different models out there they take a lot of things into consideration. They take the number of people in your community that have already had COVID. They take going back to school, winter coming, and people all of a sudden getting indoors again as opposed to being outdoors, and that closeness and getting together. And particularly, the great thing about COVID is if you stay outside and you stay a few feet from people, you probably never get it. But you put all these people in the Park Place Mall walking around, and people are more likely to get it. You get families together inside as opposed to outside, they're more likely to get it. So I think in the winter, as people get back more tightly packed and in enclosed areas, there's a perception that we'll have another spike.
Okay.
We expect a little bit of spike just off the previous weekend because you've all seen the pictures. There were a lot of people out there who were not practicing anything except having fun.
Right. That's true. Has the hospital system, initially when at the height of the initial peak of COVID, there was difficulty in sourcing all the PPE equipment. Have you been able to now recover from that? I know the community stepped up in a big way to assist, but over this time, has the system been able to recoup that and ready for should the next peak come?
Yeah, I think we feel pretty good about things. We've got a logistics center at Research Park that's about 120,000 square feet that we distribute for all of our hospitals. Again, one of the benefits of being a system is we're a big buyer, so we've been able to go directly to companies that supply. Actually been able to go directly to some companies out of China, and we've got a 6-month supply of basically everything in our warehouse. And we continue to restock as things go down, because if there is another peak, then you'll see nationwide supplies go down, and I think we'll be good through that.
Okay.
There are a few things that are nationally going to continue to be in short supply, possibly. I say possibly because remdesivir, convalescent plasma, I would have said they were both going to be in short supply, but with the latest information, I think you can see less people using that. At one time, the drugs to put people on ventilators was in very short supply. There was nothing you could do to stock up on that. But as fewer people have gone on ventilators, now we have plenty of sedation drugs, and we don't have to worry about that anymore. So It depends. Drugs worry me more now than actual supplies.
Okay.
So I think we're pretty good.
Okay. All right. Does
I
anyone
got
have
a
any questions?
question. I got a question on the chat. Somebody sent me and asked me, has COVID affected volunteer service and participation? And I would say, yeah, absolutely. Our volunteers, most are in that high risk group. So we have not brought volunteers back in large to the hospital. We miss them. They're a vital part of our organization. Would love to get them back and will as soon as we can, but it has definitely affected volunteer service. The other side of that is we have substantially limited the number of people coming into our hospital. All of you probably know it's one visitor per patient. And that has changed the traffic in our hospital substantially. Pre-COVID, we had 450 people parking off-site, and we were running bus service to get them back and forth to the hospital. Today, we don't have anybody parking off-site. That's how many visitors we moved out of the hospital with COVID. And we still got the same number of patients in beds. I think it's going to be a long time before we ever go back to a visitor situation like we had pre-COVID. When I talk to hospitals nationwide, hospitals have seen a reduction in falls. They've seen a reduction in infections. They've seen a reduction in many other clinical conditions. And a lot of people believe it's because there's fewer people in and out of a hospital bringing things in and out. Probably better for the patient. The mental piece of not having a loved one there is very difficult, though, for both the patient and the family member. We got to figure out how to address that without going back to 10 people in a room where somebody's trying to recover from a surgery. That probably never was a good idea.
Okay. All right. All right. Any other questions?
Elizabeth, I was just going to comment that it is amazing what the hospital has been able to do for our community with no taxpayer support, but COVID's a whole new world. What has been the financial impact, and have you received any supports for either through the federal government or just the supplies and testing equipment and medications? Or what has been the financial burden and impact?
So yeah, that's a great question. So the federal government has done several things to help hospitals with COVID. One of them that has helped a lot of hospitals, we weren't quite in that fix, but a lot were. A lot of hospitals had very little cash on hand, and they were looking to run out of cash. And what the government did is basically said, we're going to go ahead and front you all the money for the Medicare patients you would see based upon your history. So we're going to give you 6 months worth of cash. And then at some point, we're going to start taking that back. And when you see a Medicare patient, you'll work that off. So a lot of people got cash up front to make payroll and do those types of things. That was a loan. They also had a series of what they called grants. And that was if you took care of a large number of COVID patients or you met certain situations, they would send you money to basically compensate you for what you were doing. And we have received, it sounds like a big number, about $40 million from the federal government in their grants. Now we'll have to show expenses against all those, against that $40 million in order to keep it. So it is yours to keep if you can show COVID related expenses that offset that $40 million. And we can easily do that. Our system we ended our financial year June 30, and we broke even for the year. And that's unusual for us. We usually have a margin because that margin is what we use to pay for these buildings. And last year we broke even primarily because the last quarter was horrendous with COVID. And we figured our best case scenario until COVID is cured is to run the operation at a break even operation. And even to do that, we'll need a little bit of stimulus money. We'll need to get reimbursed for those things that I just mentioned. Early in this, the federal government said if it is a COVID-related expense, you will eventually get reimbursed for it. I don't believe that's true. I just can't believe in the end we're going to get reimbursed for all the COVID-related expenses. But, if they got enough printing presses up there to keep printing money, we're going to show them the expenses, and we may very well get reimbursed for it. we do, we'll have enough money to pay for this building over here. Although I should say, to tell us, we're getting ready to issue roughly $250 million in bonds, probably in the next 45 days, which we plan to do anyway to pay for this big building. We'll pay it off over 30 years, just like people do with a house. But if anybody's interested in buying any Huntsville Hospital bonds, there's going to be some available here before long. Not going to pay much, but they're going to be out there. It will be tax-free.
Okay. All right. Any other questions?
I have a question.
Go ahead.
In the news in the last week or so, there's been a lot of speculation about the difficulty of the logistics of distributing any new vaccines that get approved. Is Huntsville Hospital involved in that? Will you be a distribution center, or will that all be with the pharmacies outside of the hospital and with places like Walmart? And I'd just like your response, what that might mean for the hospital.
So to be determined, our drugs come through very large drug distribution companies, McKesson and some of the others that funnel all the drugs to them, and then they go out. They also supply the pharmacies and others. We have not seen how they're going to be distributed. We have been told that healthcare workers are going to be a very high priority, so we should get a large quantity of drugs in order to give our frontline staff the vaccines early in the process. We had the discussion this morning. Are we going to require employees to take the COVID vaccine? We require employees to take the flu vaccine. I don't know. I just don't see a lot of people jumping out and say, well, I think I'll go take that vaccine the minute it comes off the line. I think a lot of people are going to want to wait and see how people respond to it first. So I think even when it's available, not everybody's going to want to take it. And we'll have to make a determination for our clinical staff whether they take it or not. But I think frontline, back to I think frontline healthcare workers will be first on the list to get it. And then I think along that, also in that first group will be people who are in the high risk category, 65 and above, particularly 65 and above that have any types of comorbidities.
Okay. Last call for questions.
A quick follow-up. Is the hospital prepared to store quantities of these new vaccines? I see that some of them are going to require extremely cold storage and cannot be used after they're thawed out after about 5 or 6 days.
Yeah, again, it's interesting, timely conversation, because we had this same conversation with the infectious disease doctors last night. That specific requirement is one of the vaccines, and there are multiple vaccines that are being developed. So I don't know which one's going to hit the market, which one we're going to get. We're checking today to see if that were the vaccine we would get, to make sure we have the ability to store that drug and distribute it internally as we should. We got to learn a little bit more about those requirements though first. That was brand new information, I think, out this week, that was one of the requirements.
Okay.
And that temperature requirement, I'm not sure anybody in Alabama could do it right now.
That's true. That is a kind of a strict requirement for that vaccine. Okay. Well, unless there's a burning question, I want to thank you again, David, for your presentation today, for being with us. We thoroughly enjoyed the information you gave us, and we really did have some very timely discussions about the topics at hand. I also want to thank our guests for being with us. And at this time, I'm going to share my screen one more time so that we can move to our closing. I'll get down to it. And if you would, let us proceed to the four-way test. Of all the things we think, say, and do, is it the truth?
Is it the truth?
Truth.
Is it
Is it
fair
fair
to
to
all
all
concerned?
All concerned.
Will it build goodwill
Build
and better
goodwill and
friendship?
better friendships.
Will it be beneficial
Will it be beneficial to all concerned?
I wish everyone the best for this week. Please stay safe, and please go out and practice the four-way test this week. Have a great week, everyone. Thank you again. It's great to see all of you.
Elizabeth,
Yes.
this is Carolyn. Harry
Yes.
was able to join the meeting.
Hey, Harry, how you doing? It's good to see you.
Hey, thank you very much.
Great to see you. That's wonderful.
Like I'm sitting here with a pump on, so.
Oh, okay. Okay.
Okay. It was a great program. Thank you.
Good, good. I'm glad you enjoyed it. I did. I thoroughly enjoyed it. Mary, you're muted.
I'm
Did
unmuted.
you, I think you reached out to Katie Smith? Hold on, let me see.
I never got a response from Katie at
Okay.
all.
Because
Nothing.
Jim Tibby Paul got another notice from district about Katie, and I thought you had reached out to her. So, okay.
Yeah, by text and by email both, and I've gotten no responses at all.
Okay. All right. Thank
So
you.
I'll put that on the DACDB page that I have reached. I put that I attempted contact, but I'll document that I've had no response whatsoever.
Okay. All right.
And
Thank you.
David Pelly, I think I'm going to refer him to Rotaract if they're cheaper than our dues. He's a student and he's just a little awed by the cost.
Sure. I would understand that. Okay. All right. Thanks, Mary.
Mhm.
All right, everyone. Take care.